Hello. Yes.
Yes. Good afternoon, Dr. Piyush. You are audible.
Yeah. Good afternoon, ma'am.
Yeah.
Uh, Please let me know when to start.
Yes, yes, sure. Till now, only I think 9 participants are there, including us. So maybe wait for another
Ah,
2 or 3 minutes, then we can.
sure, sure.
Good afternoon, Dr. Piyush.
Good afternoon, sir.
I hope we can start, Dr. Shubhlakshmi. Good afternoon. You can introduce
Yes,
Dr.
sir.
Piyush Jain, and then
Yes,
I
sir.
think
Good
we can start
afternoon.
the ball rolling.
Yeah, sure, sir. So good afternoon, everyone. On behalf of Association of Physicians of India, which has taken this initiative to start this certificate course on very basic topics under the guidance of Dr. Anupam Prakash and all the leaders of API. So very basic topics which are very important in our day-to-day practice. We see the patients, but we have to know how to recognize the basic clinical symptomatology signs so that we can make the diagnosis and move forward. So for this, in this thing, we are having we have covered various basic topics, and today we have edema. This topic is very important because every system or any disease of any system can have edema as its presenting feature or any manifestation of that disease. So for this very important topic, we have with us Dr. Professor Piyush Jain. He is Professor of Medicine at RML Hospital, New Delhi. So he will be taking us through this very important topic, and I hope everyone of us will be benefited by this lecture. So over to you, Dr. Piyush.
Thank you, ma'am. So, on this Saturday afternoon in scorching heat of Delhi, I put a background near a seashore so that we all enjoy, at least, if not reality, at least in virtual, we have a background so you can pay attention to me and all to this very important topic. So, as Dr. Shubhash said, that now edema is a very important thing. Like, just a minute, I just start sharing, then I just.
Yes, it's visible.
Now it's visible. Okay. So edema, as Dr. Shubha said, it's one of the very common complaints we have in our practice. Edema can be associated, as we see, it can be associated with many different systems involved, and edema itself is not a disease. Edema is कोई बीमारी नहीं है. Edema is a problem, is a symptom, is a clue to many other system deformities. So over the next 20-25 minutes, we will discuss the pathophysiology of edema, why it occurs, what are the causes of edema, and how to evaluate and assess a patient who is having edema. So if we see the total body weight of a human body, about 50 to 70%, or we say 2/3 of it is made up of water. Even the Earth, planet Earth, is also having a lot of water, almost 3/4 is water, and human body is also 50 to 70% is water. Out of this 50 to 70%, 2/3 is inside the cells, that is intracellular fluid, and 1/3 is extracellular fluid. Of this extracellular fluid also, if we divide, 1/4 is interstitial fluid, that is between the cells, and 20% is in the plasma or in the blood vessels. So now edema represents an excess of interstitial fluid, the fluid which was around 80% of this 1/3 of the extracellular fluid, that has come increase. That is what is edema. समझ में कि जो पानी अभी वेसल्स के अंदर है उससे एडिमा की दिक्कत नहीं है, वो तो वेसल्स ब्लड फ्लो में कर रहा है. इट मे बी एन इंक्रीज वॉल्यूम ऑफ द ब्लड, बट whatever extra fluid that is accumulated in the interstitium or between the cells outside the blood vessels, that is the edema. So if any increase is there, that will cause edema. Now, why does this fluid increases? What is the reason that this fluid increases? So it may be that there is now we all know that there is an arteriole and it is going through this capillary network, and then there is the venous and or the venule is there. Now, if it is there increased pressure, hydrostatic pressure in these vessels or in this capillaries network, what will happen is when the pressure is high, the fluid will come out. So the interstitial fluid will increase. So that is one reason. Now, what is happening is out of this, when this blood goes out of these capillaries, it goes into the lymphatics and it is absorbed by the lymphatic vessels, and again it goes back into the circulation. But if there is some obstruction in the lymphatics or the lymphatics are ill developed, then this interstitial fluid will increase. It will cause edema. Now, we all know there is some oncotic pressure. Oncotic pressure is due to the, say, proteins and other things which are present in the blood. Now, this oncotic pressure keeps the fluid bound to the vessels. So that is, the fluid is inside the vessels. But if there is reduction in the oncotic pressure, like in, suppose albumin decreases, hypoalbuminemia conditions. Now, what will happen? The blood will not, this will not be able to hold the blood inside the vessels, and this blood will go out. So there is the reduction in oncotic pressure. If this barrier, now this barrier is very important, this endothelial barrier is important. If this barrier is damaged, it may be damaged due to the some infections, trauma, any reason, then this fluid will go out and cause edema. Or if the pressure here, the oncotic pressure in the interstitium is increased and it is more than the pressure inside this blood vessels, then again the fluid will move from the blood vessels to the extravascular area, and that will cause the edema. So we will see all these causes in further details, which will help us to understand this thing. So the same thing, the artery, this is a capillary bed, and then the vein, and there's a lymphatics. So this is all the game and balance of these pressures, oncotic pressure and the hydrostatic pressure inside the capillary bed and outside the capillary bed. And wherever the balance is disturbed, there will be the fluid movement will be there accordingly. So if there is so what are the causes? Well, like I discussed, the first is the increased hydrostatic pressure. So what are the conditions when the blood pressure will be higher in the blood vessels or capillaries? So it will be like congestive heart failure. If the blood vessels are dilated, so that will cause increased plasma hydrostatic pressure, and it will cause the movement of fluid from the intravascular compartment to the extravascular compartment or interstitium. Or when I was discussing that they decrease plasma oncotic pressure. The plasma is having less of oncotic pressure. It is not able to hold the water, like when the conditions is a decrease in albumin. Albumin will decrease in the liver disease. Liver is a place where the albumin is manufactured. If there's liver disease is there, like chronic liver disease, something like that, the liver is not manufacturing albumin. So there will be decreased oncotic pressure leading to edema. Renal disease, where is nephrotic syndrome, where a lot of protein is lost, albumin is lost in the urine. Again, decreased albumin in the thing, and decreased plasma oncotic pressure leading to the edema. Malnutrition, when the source is in here, albumin aa hi nahi raha body ke andar, malnutrition or malabsorption, then again this will cause to the decreased hypoalbuminemia and decreased plasma oncotic pressure leading to the edema. Impairment of lymphatic drainage. Now the vessels are not there. Fluid has come into the interstitium, and from interstitium it was supposed to go into the lymphatic drainage, but there is obstruction. Some filariasis is there. Some worms are there in the lymphatic, or the lymphatic obstruction is there. Lymphatics drainage have been hampered due to the say irradiation, surgery. After that, lymphatic drainage have been hampered. That will cause the decreased blood flow from interstitium to lymphatic, and it will cause edema. Capillary permeability can be increased in trauma, in some inflammation, in allergic reaction like angioneuritic edema. All this will cause increased inflammation, and the blood will easily flow through these capillary membranes, and it will cause edema. Now, there are two types of edema classically. One is generalized, when it is present all over the bodies, and it starts mainly in the dependent areas, but it can involve all over the body. And other is localized. It is restricted to one system or one area of the body. So localized edema causes, again, same hydrostatic pressure, like venous obstruction. You have deep vein thrombosis. Now, venous flow is obstructed, so the pressure behind that will keep on increasing. We all understand in DVT what happens is there is obstruction in the venous flow. The popliteal vein or any vein there in the lower limbs is thrombosed and the blood cannot flow further. So it will cause hydrostatic pressure outside before that, proximal to that thing, and it will cause edema there. So a lot of blood will ooze out and fluid will ooze out and cause edema. Lymphatic drainage, I'm again talking about lymphatic drainage. Now it can be congenital. Right from the birth, the lymphatic vessels are not very well developed. Like in Milroy's disease, the blood vessels are not developed, lymphatic vessels are not developed. So in the very first month of birth, there can be swelling over the body. Or sometimes that like in this Meeks disease or lymphedema precox in adolescent females, there will be edema because the edema will start developing in the 15 to 25 years of age because the lymphatics are not well developed. It's not able to take care of the fluid. Recently, we have one patient, a young female, about 22 years old. She was having unilateral edema. We're not able to find any cause. We tried for all, we'll just discuss all these things. We discussed, we investigated her for most of the causes, DVT, varicose veins, everything what discussed, but we're not able to find. Later, we did a scintigraphy of lymphatic vessels and we find the lymphatics were not properly formed, and that is why she was having edema. Lymphedema tarda, same thing, but if it develops after the age of 35 years, it a late presentation is there, then we have lymphatic tarda. So these are the congenital causes of lymphatic drainage impairment. Then there can be acquired causes like malignant infiltration and malignancy causes infiltration and lymph flow is obstructed. Infection like filariasis, elephantiasis, that will cause radiations. After radiation or surgical damage is there during after say mastectomy, the lot of lymphatics are removed and there is edema of the upper limb. It's very common to have these features. Or there can be increased capillary permeability. Increased capillary permeability, it will be there. Just a minute. Like if there is a local infection, an infection which is causing this thing, like an insect bite, it can cause, we see edema after a bee sting or some bite, there's a lot of edema is there. Why? Because that part with the toxins of the insect bite, there is increased capillary permeability, there is increased inflammation and vascular permeability that cause edema there. Trauma, we have seen many times that when there is a small trauma, there can be edema because again, the vessel is damaged, the microvessels are damaged, it will cause increased capillary permeability and this thing. Burns, animal bites, all these things can cause localized edema. Now, to maintain this balance, this fluid balance is maintained very beautifully in our body through multiple systems. Like one is renin-angiotensin system. What happens is liver secretes angiotensinogen. And whenever there's a drop in blood pressure or there's a sense in by the kidneys that the fluid volume is less, hypovolemia is there. So renin is released from the kidney and it converts angiotensinogen to which is the precursor thing to angiotensin 1. Then there is an enzyme called angiotensin converting enzyme, ACE enzyme, which is from the lungs. It will convert angiotensin 1 to angiotensin 2. And this angiotensin 2 acts on the blood vessels directly to cause vasoconstriction. It will cause vasoconstriction and it will cause decreased, it will also act on the zona glomerulata of the adrenal gland, which will secrete aldosterone, which will increase the absorption of the sodium, so sodium and water. So a lot of water is reabsorbed due to the vasoconstriction and aldosterone action, and it will increase the blood volume. Now, if this mechanism, if it goes on, it can cause increased volume and further again increase hydrostatic pressure and again edema. So overactivity of RAS can cause edema. Another mechanism which is maintaining this balance is vasopressin system. Now, what happens is whenever there is hyperosmolarity, that is, there is lot of fluid and hyperosmolar state is there, like if the glucose is raised, sodium is very high. So this will be sensed by the hypothalamus. Hypothalamus will ask posterior pituitary to secrete vasopressin. Now, vasopressin will act on the blood vessels, systemic blood vessels, and it will cause a lot of vasoconstriction and increased reabsorption by the kidneys of the sodium and water. It will cause increased blood pressure. So again, these are check mechanisms to decrease edema, but once they go wrong, or whenever they're not well balanced, it can cause edema. Another is this ANP and brain natriuretic peptides, which are secreted by atrium and brain. So again, they are stretched thing. Whenever the volume is increased, now they are the negative things. When the volume is increased in the atrium, they are secreted or released, and they will cause increase in the excretion of sodium and water, thereby decreasing the blood volume. So as I said, that edema is a common problem. We see it very commonly. Many patients comes to us with problem of edema. So whenever we are seeing a patient of edema, if someone comes to edema, we should take a proper history. Now, this is true in all medical scenarios. So what history is required is what type of edema is there. Is it generalized or it is localized? Because as we discussed, localized can be having some local causes. वहीं का कोई लिम्फ खराब हो गया है, वहीं पर लिम्फेटिक्स खराब हो रखा है, वहीं पर कोई एनिमल बाइट है, कोई बी बाइट है, कोई लोकल इन्फेक्शन है, कोई फंगलाइटिस हो रखा है, कुछ हो रखा है, इन्फ्लेमेशन हो रखा है. सो व्हाट इज इट? सो इज इट लोकलाइज्ड और इट इज जनरलाइज्ड? नाउ जनरलाइज्ड एडिमा, it will involve all the parts, but it will be more prominent in the dependent parts. Like dependent parts means ankle, foot, legs, it will be more prominent. Or when the patient is lying down, it may be more prominent in the back and sacral area. So we have to look whether it is a localized edema or it is a generalized edema. Then what is the duration? How long this edema have been present? Is it for a short duration? It is an acute cause, or it is a chronic or long-standing cause. Now acute, if we talk about the lower limbs, acute edema, it can be due to DVT. DVT will be an acute presentation. For the last 2 days, patient is having swelling and pain over the right lower limb. That is an acute presentation. So it can be due to the DVT. Chronic, if it is for long time, it may be like long standing because of the venous incompetencies, varicose veins. So it will not be one day single presentation. आज अचानक से सूजन आ गई है. It will be for long standing. For a month, I have been developing swelling, and slowly it is increasing, or it is now more frequent. So that might be due to the chronic venous insufficiency or varicose veins. Then we should ask for is history of any precipitating factor. Is there any factor which have caused the increased swelling, like trauma, damage to the endothelial cell, capillary membrane, cause infections, allergens? You might have seen a patient coming with this lot of swelling over the face, lips, even threatening to the larynx. So that might be just due to the allergic reaction or angionotic edema. So we should have those history. What is the age? Is it right from the birth? It might be due to lymphatic congenital non-development of lymphatics. Adolescence, it might be due to the lymphangia precox. Or is there a drug history? Many of the drugs are known to cause edema. Like they're common drugs. Antihypertensives, commonly used calcium channel blockers. That's why amlodipine, commonly used. It can cause pedal edema, bilateral pedal edema. Then antidepressants like MAOs inhibitor, MAO inhibitors, they can cause chemotherapeutics, cyclophosphamide, cyclosporine. Then hormones, corticosteroids, very common. We are if the patient is taking long-term steroids, they might be having fluid retention and it is causing edema. So when we see many patient just comes with edema and you ask कि कोई दवाई खा रहे हैं, हाँ ये steroid चल रही है सांस के लिए या किस चीज के लिए, rheumatoid arthritis के लिए, and that is causing a fluid retention. Then diabetic drugs like this thiazolidines, they can also cause, because they will also cause fluid retention. That can cause edema. Even non-steroidal anti-inflammatory drugs like celecoxib or ibuprofen, they are also known to cause edema. So we should have a good history, why any drug the patient might be taking, which is just causing the edema, instead of just going on to the investigations and other tests. The urological surgery, any recent surgery, any mastectomy, any surgery which has led to the removal of lymphatics, radiation history, all these points should be asked in the history for the edema. Then what to do if all these factors are not present or they may not be conclusive of the cause of the history, then we should look for the other associated features. One is cardiac. Now, cardiac heart failure is a very common cause of pedal edema, dependent edema. So we should look for the history of cardiac history, like dyspnea, orthopnea, paroxysmal nocturnal dyspnea. These points might be just giving a clue that the edema is due to the cardiac causes, or it may be the liver failure. Signs of liver failure, symptoms of liver failure like jaundice, pruritus, abdominal distension, hematemesis, or even the hepatic NCAF, they should be looked for. If you're just looking for the edema, look for these symptoms, ask for this history. If these are there, it might be due to liver disease. Or if there is a history of periorbital swelling, early morning periorbital swelling, frothy urine, hematuria, frothy urine due to proteinuria. So these might be that the renal is the cause of edema, nephrotic syndrome might be a disorder. That is why the patient is having this edema. Simple malabsorption, weight loss, diarrhea, anemia, all these can point out that the edema might be due to malabsorption. Then venous thrombosis. A patient might be having a history of long-term bedridden and then develops edema. There might be DVT, long-standing, might be varicose veins. You should look for that. Thyroid symptoms. Patient might be hypothyroidism and then developing the edema or even mixed edema. The patient might be having pedal edema. So if we see common causes of leg edema, now we have to see whether either it is unilateral or it is bilateral. If we see unilateral, the recent causes or the acute causes might be DVT, ruptured Baker cyst. The Baker cyst in the popliteal fossa and it ruptures, it can cause edema. Any injury to the leg muscles, compartment syndrome, intramuscular hematoma, infection, fractures, trauma, that all can cause the unilateral recent edema. And chronic primary venous disease like post-thrombotic syndrome, vein compression, vascular malformation, CRPS, simple thing. CRPS just causing edema. You're looking for all the tests, investigations done. They might be negative. It might be just reflux sympathetic dystrophy. Then if you see the bilateral, again, bilateral DVT, bilateral heart failure will cause bilateral thing. Even liver disease, liver failure will cause bilateral. IVC thrombosis, liver failure, renal failure, drugs, these will cause bilateral. And chronic again is the chronic venous insufficiency, pulmonary hypertension, heart failure, liver failure, pregnancy, obesity, malabsorption, thyroid disorders. All these can cause bilateral chronic edema. Now to examine, we should again look for distribution, which all parts are involved, whether it's a localized edema, whether it is pitting or non-pitting edema. Now, pitting edema is generally due to the fluid and due to the increased vascular permeability or due to the increased hydrostatic pressure, which is causing the fluid there. And non-pitting is when the lymphatics are damaged, when the fluid is not able to move out of the interstitium, that will cause non-pitting edema. Pitting edema will be there in the cases of like CHF, liver failure will all cause pitting edema. Then we look for the cardiovascular system. We look for the signs of heart failure, raised JVP, S3 heart sound, any murmurs in the heart. These can give, or hepatojugular reflux. These all will give the signs of heart failure. We do an abdominal examination, look for the signs of liver failure. Signs of chronic liver failure. There may be ascites, splenomegaly. There might be spider angiomas, Dupuytren contracture, anything like these signs can point that this patient is having liver failure and that's why there is edema. Examination of lower limb should be done. Look for the signs of any DVT, look for filariasis, look for varicose veins. Signs of thyroid disorder might be there, symptoms of hypothyroidism might be there, weight gain can be there, which can cause edema. Signs of malnutrition should be looked for, anemia, all this should look during the examination. So this is a normal foot, and when we press, this is a pitting edema. Then we press, it does not, it shows an indentation, it does not recover immediately. And they have given some grading also that if we press, it is 2 millimeter, 3-4 millimeter, how much pitting is there. So if we get some clues in the history and examination about the liver failure, then we go for investigations. Now, first we look for the common investigations like the CBC, which can show there is history of anemia, there is increased TLC. KFT can be done, which will show the derangement in the urea creatinine, if the liver problems, if the kidney problems are there, if the liver problem, there might be jaundice, there might be raised OTPT. Serum proteins, this is very important. You might get a clue with the serum proteins because there can be hypoalbuminemia, and then the cause can be looked for. Urine analysis, very simple test, cheap test, but not done commonly and properly. So we should look for the urine analysis. If you find a patient of edema, go for urine analysis. You might just find there can be a urine proteinuria might be there. Thyroid profile, to look for the thyroid disorders as a cause of edema. These are the basic tests. Then we can get some special investigations. If we are looking for a lower limb swelling, we can get a venous or arterial Doppler. If we suspect DVT, or if we suspect the chronic venous insufficiency or varicose veins. If we are getting protein presence in the urine, we can quantify it and look whether the nephrotic syndrome or nephritic syndrome. We can get a 24 hours urinary protein done. Then echocardiography, if we are suspecting the congestive heart failure as the cause of edema, then we can get echocardiography done to look whether the heart failure and what are the ejection fractions. Lymphangiography can be done to see for this if the lymph vessels are not well developed. Pelvic ultrasound, malignancy, because malignancy is one of the cause which can cause pressure on the veins or even cause malnutrition, and that is why we should look for the pelvic USG to see if it is causing the pedal edema, and again CT for the malignancies. Now, if we see the management wise, it is according to the etiology. First, find the etiology, and accordingly we manage. If it is the heart failure, we have to manage the heart failure part. We have to give diuretics. We have to manage the heart failure. That will help us. If it is a liver failure, we might need to give albumin, or we need to manage the, again, diuretics will be helpful in the liver failure. Renal failure, accordingly management. We have to control the proteinuria there. So we might need the ACE inhibitors to control the proteinuria, or steroids if required. Raising the limb, non-conservative measures, raise the limbs. Many times the edema will settle because it will increase the flow, in, especially in the when the dependent part edema is there, diuretics and albumin therapy. So they are generalized cause of edema, but it can be very localized cause, like just cerebral edema. Edema in the brain can cause cerebral edema. There can be macular edema, papilloedema, pulmonary edema. If there is the this there are a lot of respiratory problems, it can be due to the pulmonary edema. So these all can be subsets of the edema, but mainly it is the increase in the interstitial fluid. But how it is localized or it is generalized, that has to be seen. Thank you. Thank you, ma'am. We can have discussion.
Yes, yes. Thank you, Dr. Piyush, for wonderful talk. If there are any questions from the participants, we can take in the
There
chat
is a
box. Let
question
us
in
check.
the chat, Dr. Piyush, for you.
Yes, see, sir.
Many patients with bilateral pedal edema, pitting type with echo normal, LFT, RFT normal, albumin levels and thyroid profile normal, negative drug history. How to proceed, and can we give Lasix, furosemide, I mean, symptomatically? And if patient improves with furosemide, now how to evaluate for cause?
Now, first thing is whenever we are looking for these type of patients, we should, like you said, we do all the investigations and see what is the cause. It is a renal cause, it is a liver cause. But as I said, sometimes there can be transient edema for which, or there cannot be a cause may not be find out. And symptomatically, they can be relieved with diuresis. So we can try, but if it is having recurrent, then we should go for other causes. We should look for the malignancy, and we should also look for the lymphatic derangement. If lymphatic derangement is there, that might be the cause of edema persistently. And drug history, otherwise drug history. Look for the drugs which are, drug which is the patient might be taking, which is causing the edema.
Well, very right, Dr. Piyush. I would just say if you have bilateral pedal edema, you should always think if you have ruled out all the other causes. Check for chronic venous insufficiency. It is a very important cause. And with rising age, even in youngsters, if they are standing for very long hours, you can have. So, as Dr. Piyush said in his last slide, the conservative management, limb elevation, then don't stand. If you are even standing, if you are forced to stand, there is no other option. Keep moving your legs. That will at least keep the calf pump, the natural calf pump will actually put the fluid, the interstitial fluid back into circulation. The lymphatics will be active. So those are the ways that you can do away with. And at times there is an entity called idiopathic edema, wherein you will have you will not get any investigation which is there, which is positive, and edema will still be there. So in those empirical cases, yes, you can use antioxidants, you can do with a small dose of diuretics, and at times this improves. Especially in females, at times you can have menstrual edema or the idiopathic edema where you can have diurnal variation, you can have menstrual variation. So all these things you have to take into account whenever you talk of edema without any obvious cause. Mind you, if you have bilateral pedal edema, always search for whether it is pitting or non-pitting. If it is non-pitting, then always rule out pelvic tumors. There could be a tumor which is there and causing lymphatic obstruction. Not only chronic venous insufficiency, but it could be a lymphatic obstruction. Dr. Piyush has very nicely mentioned that at the very beginning of his lecture. But at times we know all the causes, but when it comes to the patient, we are not able to execute or evaluate. So that is just one point I thought I would just add.
Yes, sir.
There is another query, Dr. Piyush. Yes, Dr. Piyush,
Amlodipine and
please.
other drug-induced edema. No, that is not fixed. What time whether it will be initial phases of the drug initiation or it will be late phase. Generally, with amlodipine, we say that the long-term use can cause, but in some patient it can be in early period also. So we cannot say at what time of this the edema will develop. But if edema is there and we are suspecting it due to amlodipine or any drug, we should try to change over the drug.
Well, very rightly said. Amlodipine, we have seen clinically patients can develop edema even after 2 years, 3 years. Long-term therapy they have been taken and they can develop as late, not only months but years later. The other thing is, as Dr. Piyush said, change over to another calcium channel blocker or a newer generation dihydropyridine calcium channel blocker, which can obviate this edema. And at times, changing the dosing pattern. There is a concept that if you make amlodipine nocturnal evening dosing, that can also partly do away with the symptoms. But yes, any patient who is having more than 5 to 10 milligram per day will definitely develop edema sooner or later. There is
One
another
thing to
one
add,
for you,
sir.
Dr. Shublakshmi.
Yes,
Yes.
sir.
Yes, ma'am.
Sir, sometimes what it happens is sometimes patient is having taking 10 mg of amlodipine. If you reduce it to 5, sometimes it take care of the edema in some of the patients. Not always, but yes, this can take care of edema.
Higher doses are more commonly associated with edema. That is true. More the dose it can be there.
Role of dietary factors in development and management of edema.
That we've already discussed. If the albumin is less, if the patient is taking less of proteins, it can cause edema. And management of
Cilnidipine can cause pedal edema. Yes, all calcium
cilnidipine
channel blockers. Yes.
so cilnidipine is less likely to cause that compared to amlodipine, less likely to cause the pedal edema. In fact, it is that many have said you should give cilnidipine if the amlodipine is causing edema. The newer, as sir said, newer calcium channel blockers have less of pedal edema. Venous insufficiency other than DVT, sir.
Yes, venous insufficiency other than DVT. That
Very
is
good.
what I was talking about. DVT will cause irrevocably unilateral pedal edema. Chronic venous insufficiency, bilateral pedal edema at times, and at times unilateral if there is femoral, saphenofemoral valve incompetence.
Varicose veins is the part of the venous insufficiency, and that will cause edema.
Yes.
How to differentiate if patient having hyperthyroidism and pitting edema, some case. Hyper.
Edema is not a characteristic cause of hyperthyroidism is not a characteristic cause of edema. So you will have other symptoms for hyperthyroidism if you are searching for hyperthyroidism.
In patient with use glycerin and magnesium sulfate symptomatically. See, if it is a very superficial edema and cellulitis, then this can be used glycerin, but most likely it will not be very useful. But it is very severe edema, it is causing blisters and all that thing. So superficial edema is zoometric, then you can use all these drugs. Management of painful bilateral pedal edema in hypertensive patients. Again, we have to look for the cause. What is the cause of this painful edema and manage accordingly.
It is usually not painful, but it is more discomforting. That is what is even in the last question. If you have to use glycerin or magnesium sulfate, it is only if it is discomfort. And the thing is, as Dr. Piyush rightly said, you have to remove the cause. On one hand, it is moving, the fluid is moving from the intravascular compartment to the interstitial compartment, and you are taking it out using glycerin or magnesium sulfate outside to the exterior, will not remove the edema or the source of edema. So you have to correct that pressure balance that Dr. Piyush said very rightly in the beginning. So symptomatic management, you cannot just remove out edema. You will have to correct the cause and identify the cause, which is not going to be an easy job. Dr. Piyush, you have a whole lot of questions. There are
So
CLD patients with edema not responding to diuretics and spironolactone.
yes, if albumin is very low, and so you can give albumin to the patient, that will help us in responding to the edema of CLDs. If you've tried all the diuretics and still it is there, so you have to build up the albumin.
How to diagnose lymphedema?
We have discussed, we look for the other tests, and then you can get a lymphangiogram, scintigraphy can be done, which can show you how the vessels are there, lymphatic vessels are there. Lymphangiogram can be done. Elephantiasis patient, will we give, why professor will treat the elephantiasis? We will treat with the drugs. Because there is
And at times you can treat the disease, but elephantiasis may persist.
The worms are obstructing that this thing lymphedema. You just give them the drugs that will help. But yes, if it's a chronic, then it will persist.
Well, I think there are going to be lot many questions. See, there are some more, Dr. Piyush, because it is such a common entity.
Chronic lymphatic stasis.
Incidence of idiopathic pedal edema. There are different studies. Some people have series of idiopathic edemas they have reported. It is not a very common entity. Nobody studies edema because, as Dr. Piyush said in the opening sentence, edema is a manifestation. So people study diseases, manifestations, clinical manifestations. That is why this topic of clinical medicine is there, to get into the midst of things and importance of clinical medicine. So we don't have many studies on idiopathic edema, and I don't think I have encountered any new study in the last 2 decades. So whatever I was talking about was way back, maybe early 2000s, at the turn of century. Dr. Piyush may like to add something.
Sir, it's mentioned in the textbooks, and we just but many times we don't find the cause. We try to treat them with conservatively, and they respond. So we label them that's idiopathic. But how much incidence is there exactly? That is difficult to comment. Definitely, sir.
Chronic lymphatic stasis, patients and filariasis, how to treat flares.
Chronic lymphatic stasis, patients in filariasis. So
Basically, acute lymphangitis flares, yes.
we are treating the filariasis, and doxycycline or used in
DEC is the standard of treatment that is usually used.
for 4 to 6 weeks. We use the treatment. DEC should be used.
Lot many questions. That is hats off to Dr. Piyush, and I think with the permission of the hosts, thanks to Dr. Shubhlakshmi, we will close the session. So last comment is also thank you, sir. Thank you, Dr. Piyush, for an enlightening session.
Thanks for
And don't go by his looks. He is not as young as he looks. He's a very senior professor at RML Medical, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. So this video will be available shortly by evening or maybe tomorrow. They are all posted on the group. So past videos are also there and they are there. And the courtesy Dr. Kamlesh Tiwari and his team, they are 3 Dots Life Sciences. They are posting it on the group only. So you can have a relook at this. Well, thank you so much then. Thank you. Thank you, Dr.
Thank you,
Piyush.
Dr.
Thank you,
Piyush.
Dr.
Thank
Shubhlakshmi.
you, everyone.
And thank you
Thank you,
everybody
sir.
for joining here.